Day session. Today's topic is food insecurity among older adults, and I know most of you. I'm Shirley Girouard. I'm one of the co-directors of the Bridge and GWEP project, I'm going to be doing a couple of things today. I'm going to tell you about a project that we did here at Downstate, but most importantly, to talk about some of the options that exist for you as care providers, the kinds of things you might be able to do. And then also, and this is why I'd hope we would have a larger group, is to provide opportunities for some possible research or demonstration projects that might be of interest to students who are involved, and whether or not you might like to be engaged in some of this work around food insecurity. So let me tell you first a little bit about some of the people that have been heavily involved in the project. Kim Vallejo is with the Department of Agriculture and Markets for New York State, and her role and the role of Jelani Dushong, who is Director of Government Relations here at Downstate, will be important as we go along when we talk about this project. The other people I'd just like to acknowledge and also are important in the project and its success, we're our Interprofessional and Community Advisory Committee, as well as the faculty, students, the community agencies, and the older adults of Brooklyn, who really all were amazingly engaged in this project throughout. Also to recognize Dr. Michelle Soloway, who's a researcher and co-author of this work with me, and Carlene Lawrence, who many of you know, who volunteered with us in the early stages, and that's how I got to know her, and recommended that she might consider working with the GWEP project. She is one of the other co-directors of GWEP. So, all right. Food insecurity, I'm sure, is something that you haven't missed out on. Whether it's been part of your curriculum. Certainly there's been plenty about it in the news, in both print and on television, on radio, that food insecurity is an amazingly significant problem in this country. And I'm going to be talking from the pre-pandemic data, but I also have some more up-to-date data for you. But this relates to food shortages, disturbances in eating and reduced food intake, which are due to a variety of causes, which we will talk about a little bit. Before the pandemic, it was estimated that there were 50 million Americans who were subject to food insecurity. And almost 10%, and this is a little bit old data, of older adults were food insecure. And there was recognition, and this is probably 5 years ago or so, that older adults were the fastest growing group impacted by food insecurity. The reason why Brooklyn came into play was because of a number of things that were going on in New York State and in the city, but also because of the disparities in food insecurity, with rates of food insecurity much higher among people of color, particularly African Americans, people obviously living below the poverty line. And another reason why Brooklyn was of interest were so many people did not have a primary care. And I have doctor here, I should change that to provider, sorry, to my other colleagues. And we also have, as you all know, a higher rate of health disparities and comorbid conditions in the community of Brooklyn. At the time that this was going on, the Governor Cuomo, and it still is ongoing, has a Vital Brooklyn initiative, which is intended to address a lot of the social determinants of health across the community of Brooklyn, as well as other areas of New York City. Now, this is just a map with the darkest orange area, the areas with the highest food insecurity, and you can see there are good portions of Brooklyn, also the Bronx and the Queens, but Brooklyn has the largest amount, making this a really compelling problem for New York. So recognizing that this was probably a problem for older adults in our community, the New York State Department of Agriculture and Markets approached the university through the president's office, asking if we would partner with them to do something to address this, this project. They had a couple of ideas, and then with a project led by the College of Nursing, we worked with them to develop some approaches as to what we might do. And where we started and where we ended up were a little bit different, and I'll tell you a little bit why, so you can get a sense of how things evolve in real life when you have a great demonstration project, but then other factors intervene. But our project did include opportunities for teaching and learning, as well as service to the community, and there were also some research components. These are the objectives of the project, all of which remain today. We have by no means finished the work that we are doing. We've made some strides in meeting all of these objectives, and I'll talk a little bit about each of them as we go along. So the way we started this project was, obviously we did a literature review first, as you would with any evidence-based practice or research project, to find out what was going on in relation to screening and referral and interventions, because we wanted to find out something we could do to make a difference. We formed the partnership that I talked about. We had community members, we had representatives from some of the legislative offices and the city council or the Brooklyn Council. One of the other things we did was we created a tool that was relevant to our community. And I'm going to talk about that in a little more depth, and I can share that with you if we have time. A big piece of the work that we did that ended up being an even bigger piece were health fairs and community education projects that were done. We did about 15, I think it was, and we did some surveys of people. And again, I'm going to talk about that in a minute. And then another piece that actually started early in the project with a community health nursing student activity was starting some asset mapping to find out what resources were available in the community for healthy eating. And we renamed our project from Food Insecurity to Healthy Eating for Older Adults, and a logo we put on our giveaways and so forth. If you're not familiar with asset mapping, and if you're involved in public health, you certainly are, but asset mapping is something that's been used a good deal in public health, and it's a way to find out where resources are available. And there's also mapping that's done, sort of problem mapping, to find out where issues are, and you know that from data that you've seen about the incidence and prevalence of different diseases. But this is on a more positive note, is looking at where are the assets in the community. And the students actually did this, the nursing students started this, and it's being continued with the help of the IT program on our campus. So a big piece of the work that we did was around developing an assessment tool. There, we had actually a medical student, a third-year medical student, did an extensive review of the literature and found all of the different tools that were being used for assessment. And what it boiled down to, and one of our reasons for wanting an assessment tool, was we wanted something that would be easy to use by primary care providers, so that primary care providers could assess the food insecurity among the people that they saw quickly and easily. And there were two questions that related to finances. You know, did you have enough money? Were you afraid you were going to run out of enough money to buy food before the month was over? And that's been used as a screening tool. And we were looking for something a little more than just that gross screening, because we realized that what would we do when we got answers to those two questions? We needed to know a little bit more about the people who were at risk for food insecurity, so that we could come about developing a better intervention. So we spent a good deal of time developing a tool, and I'll share with you by way of the findings some of the things we included. But we wanted to know a little bit about the population of older adults in Brooklyn in relation to what kinds of chronic conditions they had, what kind of physiologic problems they had, a little bit about what kind of food they ate, because one of the things that's really important, there's a lot of information put out there, sort of that's the American, I don't know what else to call it, diet, but there are a lot of we knew that there were a lot of residents in our community that didn't eat the traditional diet. All you need to do is to go into some of the produce markets around the community of Brooklyn and find fruits and vegetables there that some of us may not be familiar with. So we want to know more about what people ate and about how they prepared their food and how they got help with their food, which didn't commonly occur in most of the tools that we saw. So we developed this 2-page tool, and our findings, it was clear, and I'll share a little bit more detail on that data in a minute, that food insecurity is indeed an issue for the older adults. We had a 2-page survey that I was alluding to that talked about, we asked the traditional questions about food insecurity and then asked some of the others, and then asked some sort of demographic variables about food and about where they lived and what resources they already had. The majority of the respondents had 2 or more health problems. That was like 70 some odd %. As I'm sure you will know, is that diabetes was way up there along with obesity. The other thing that we found out that was, I don't know, somewhat of a surprise, I think, that the demand for information was really significant. We were on our way to beginning to switch from doing our community work and our survey work to developing some screening tool processes and some interventions for the primary care practices in the community. When a number of elected officials got word of what we were doing, and it became, how does one put it, a challenge, because the elected officials wanted to have our food insecurity booth with the education and with the surveys done among their constituents. So we added a number of different events to our calendar and put our primary care piece on hold in order to meet the requests of the legislative officials. It was a very interesting process. Some of it that it was very political, and there was a great demand and all kinds of interaction between the governor's office and the legislative offices. So that was an interesting sidebar. But some of the things we found is that a significant proportion of the community are at high or moderate risk, with 22%, almost a quarter of the people that we surveyed, and there were 369 surveys that we were able to use from the 400 or more that we actually looked at. And this is based on our using those questions that we talked about and combining them into a scale. So food insecurity is indeed very high among the people that we surveyed in Brooklyn. Keep in mind too that we didn't interview the most vulnerable, because these are people who are out and about in the community, able to attend their church health fair or their fair in their local park. So although they had many conditions, they were still out and about in the community and were not homebound, and were able to participate in the project, telling us that there indeed were more people who probably were not as able to get out and about, who also had issues with food security. One of the things that I think is really important, again, of those people who are out and about in the community, 3/4 of them needed help with shopping and with meal preparation, which was very interesting. 40% of them participated in SNAP, and we know from our conversations with them that number was low. We should have seen that number a good deal higher based on income levels in the community. And what people told us was that it was too hard. The forms were too hard. And we'll talk about some of the policy implications of that in a little while. And then 33% of the people that we saw had some kind of help in the home with their activities of daily living. Again, painting a picture of the community and what the needs of our community of older adults are. This was something that was not a surprise, but was really helpful to us as we think about what's going to be next. More than half of the people, the primary type of food that they ate at home was Caribbean. So one of the things that Carlene is going to help us do is to divide some of those food plates that you've probably seen the Food and Drug Administration put forward, the Department of Agriculture, telling you what to put on your plate. And as one physician at Maimonides said when he went by our display, none of my patients would know what those foods were, the ones that we had on our plates, the ones that we got from the Food and Drug Administration. So one of the things that's next is to develop some that are specific to different cuisines, if you will, in the community when we're helping people identify healthy eating. And as there's a presentation that we can think about doing later that Carlene does, which actually gets into some of the foods and gets into how to do, how to select foods and what kinds of foods and how to do this in an economic way, economical, I guess. This is again what I alluded to earlier, the number of conditions among people in our community, more than half with hypertension and high cholesterol and diabetes and obesity right up there. We should really separate the over and underweight. I don't remember any of the people whose surveys that I either helped them to complete or that I looked at sort of roughly or reported being underweight. I may have been one that I can remember. But overweight and obesity is indeed a problem in our community. So one of the things I think that I've been giving some thought to, and I'm sure you have as well, is that with the COVID-19 pandemic, and this has been in the news with pictures of lines at food banks and a lot of discussion about what's going on. And as I alluded to earlier, with older adults being among the more vulnerable. And in our community, older adults, people of color, people who live, who have low income, people who live in places where there isn't good access to food are certainly going to be affected much more greatly than others. This really represents, and I have an article on the bottom referenced here by Fitzpatrick and Harris about how serious a threat this is to national health. And I think it's getting some popular press. I know in my consulting work with the Council of State Governments that this is something that's talked about both by the Rural and Agricultural Committee as well as the Health Committee. The disruptions in the food supply chain, and probably many of you witnessed this as well, and we don't have the same sort of vulnerabilities as many of the people in our community, that it was difficult to get some foods because providers and businesses were shut down, especially early in the pandemic. And there still is disruption in the production of foods beyond the farm and getting those foods out to the communities. The social vulnerabilities and the individual vulnerabilities that are in our community are even more apparent now with the pandemic, and not unfamiliar to those of us on this project because we talked about many of these things. Country of origin does seem to make a difference. And in relation to marital status, that refers to men having a greater vulnerability, as they do with many of the social determinants. And then as individuals, and this is true in a couple of things that I looked at, depression, fear, and anxiety have also added to people's struggles. I think the fear and anxiety, it's fear and anxiety about contacting the virus and being out and about in the public. And I think that that certainly adds to significant problems for our older adults. So there's a number of implications for all of us as providers. And in the time that we have left, I thought it might be helpful for us to talk a little bit about what, as providers, you think some of the ideas you have for patient care and education, both, and then also what kinds of things might you do in practices? You know, if you're in a group practice, doing some population health interventions, how might you partner with the community? And then what kind of policy actions might you consider moving forward? And I think for those of us who are clinicians, I think for everybody, but poor diet is the leading cause of poor health. And I think we know that, but we don't often think about it in relation to people's access to food. We often think about it in relation to their behavior and the things that they elect to eat or don't elect to eat. But food insecurity certainly exacerbates poor diets. So let's unmute yourselves and show your faces, and let's talk a little bit about what are some of the things you think you might do or are doing as providers to address issues of food insecurity. Andre?
Yeah, I don't think we can show our faces, but can anybody hear me?
Yes.
Yeah. So as a provider, no, we know food insecurity has two components to it, as you mentioned. One of them is access, and another one is availability. And as we all know, the pandemic has hit hard, and there are many households in the U.S. that have been hit hard, and there's also rising poverty and rising need for food stamps and all those. So in a practice, I had come across a couple of concerns, because food disparity also in relation to racial disparity. Some of my patients complain that the food that they give them is the same food every day, and it's like frozen food. And they don't really like it because they're eating the same thing every day. And as a provider, so one of the ways to solve this issue is to kind of increase patients' access to food. Like there are many centers that provide that supply food at home, like Meals on Wheels and God's Love We Deliver. So as a provider, I would like to increase access to the patient, give them information about the availability of those resources. And secondly, like enact some government policies, like Trump just signed, like yesterday he signed the bill. He was trying to get it from $600 to 1,000 to 2,000. I don't know how far that's gonna go. They were supposed to vote today. So those are some of the like policies that I would try to push for to increase like food stamps, increase help aids in the form of financial aids to people to increase their availability. Because even now that the pandemic has hit hard, there are also a lot of food deserts, like you mentioned. There's a lot of food deserts. People don't have availability to healthy food alternatives.
You raised some wonderful points. One question I would ask is, do you have resources in your practice that you can share with your patients about where they might get access to healthier food?
Exactly, that is the point. Like when I was doing outpatient, we work at the veteran hospital, and we don't have like handouts, but we could like, from what I know as studying public health, I kind of know some of these resources, some of the food banks and some of the some of the companies that supply food.
Mm-hmm.
But it is something that I could ask the social workers. Maybe they know that maybe they have resources. I haven't actually like referred patients there. I just happened to tell them by myself because I knew some. Yeah, but I think it'll be a good. I will like when I go back. I think I would like to ask the social work if they have such like flyers and.
Yeah. Yeah, I was going to ask Clivia, do we have anything like that in any of our clinics?
Dr. Girouard, Clivia is with the patient right now. There's some sort of emergency.
I used to work in the Bronx and like outside certain hospitals, and they have this in Brooklyn as well, where for seniors, especially since we're geriatrics, they do provide like farmer markets, like vouchers. Like
that was what we were doing, yeah.
And you know, patients really responded well to that. You know, I believe there's different ways to apply for it. Some of the ways, which might be a little hard for the geriatric population, is online. But you know, some of the markets did have like these stands if they were in the vicinity of the hospital, where they could get signed up for it. There was these walking groups that would do like walks in parks and things like that, and they would attract members that way. And then say, if you walk with us, you can get like a voucher for this week. And that was how some of my patients got access to it. And this is when I was in a private practice, so I didn't have like a social worker on hand, but it was sort of just what was in the area and what I found out for them.
Great. So my sense is that that's one of the things that we can do through our GWEP project is we can find out if we didn't turn up any resources, we created some resources. But there are some groups in the community that we could partner with and continue our mapping. And so we can get that in the hands of the providers as to what's available. And in particular, to be sure that like the senior centers have access to this information because their folks are great about reaching out to people in the community. And the churches as well. We did a lot of work with the churches in our community who are very active in trying to address some of these concerns. Let me ask you, as providers, do you include screening for food insecurity as part of your routine? I know Kings County does include it in their intake for, at least in their geriatric clinic.
Yeah.
The VA has it built into sort of your reminders for certain patients if it hasn't been addressed, where it's like, oh, you know, do they have living insecurity or food insecurity, which the first part is the living insecurity. And if you answer no or yes to that, then it will ask you if they have food insecurity issues.
Okay.
Excuse me, Dr. Girouard, excuse me. On that note, you said the veterans had that. Is that right?
Mm-hmm.
It's built into their reminder system.
Okay, because on that note, I would ask if the primary care people are asking the population if they in fact are veterans, or if they have anyone in their family who is, because that's a whole additional initiative that's kind of operating out there where we are missing the overlay of the health problems related to military service. So you may see a health problem, for example, but not realize it in the broader context you need to as having being a veteran. So I guess I'm looking at kind of both ends of that spectrum from two distinct yet related aspects. Because maybe, again, partnering more with the veterans to think about how are they addressing that when they, in fact, do get yes answers. And on the community end, what do they do then for their veterans living in that community? So I'm just thinking maybe the Veterans Administration might hold an opportunity for us.
Yes, and to link people up, because the veterans sometimes have services that are not available to everyone else in the community. So that's a great thought, Kathy. Thank you. I don't think that downstate. Do you have this? I'm sorry, none of the clinicians from our group are with us today. I don't know if it's part of the regular screening that we do in our primary care practices at downstate.
I don't think downstate has it. Downstate doesn't have screening.
I didn't think so. So there's certainly an actionable item that GWEP can do, and when we think about, you know, as we do with all of the work that we're doing, putting this in the context of age-friendly practices, certainly one of the most important things I think that we need to ask is what's important to our patients. We often don't even think about asking them about how important food is in their lives, whether it's for their health, or food is such a socially important thing. So, and I think that's something we should, I'm making notes on these ideas. So food as a what matters. I don't think we've talked about that sort of specifically, but I think it's important. And I think we're reminded of that around the holidays, and the importance of meals and people being together and eating certain foods around different holidays and how important they are. And that we need to take that into account, even when there isn't food insecurity, but when we're helping people to eat healthy, our older adults to eat healthy, how can they make their traditional foods so that they are not as salt laden or as fat laden as they do. And I was just making a note that we probably should talk a little bit more about nutrition in general and adaptations for older adults. And that's an area that Carlene Lawrence can be very helpful with us. But because many of our providers tell us that nutrition is a very small part of their education, and yet we know it's a very big part of health. So we're always trying to do catch up around nutrition and giving that task to the nutritionists or the dietitians, and yet we don't always have those resources available. So something we should think about on our GWEP project and moving that into the forefront. Well, we only have a few more minutes because we need to get ready for the 4 o'clock, and I have a telehealth event coming up in 5 minutes. And I think you've raised a lot of the issues. One is to make sure that we build the assessment into all of the work that we do in a way that's cost effective, and then also that we make sure that all of our primary care providers and our other care providers have some easy, quick bits of information that they can give to people when they do identify that they are food insecure. And then the idea of our sort of triage kind of 2-page food insecurity tool was to help weed out those people who are at the highest risk. Our plan, which we're hoping we can get some funding to move forward on, our plan is to be able to identify those people who are at highest risk and get them nutritional consults. Some are covered by insurance and Medicare and Medicaid, some are not. And so we wanted to find a way to weed that out to make it easier for the primary care providers meeting with patients and the practices to be able to identify those people at greatest need. So we'll keep pursuing that. And we identified some things working with the community as well, especially around education and dissemination of information about how to eat healthier. And then some of the policy actions and without a doubt that the things that are going on at the federal level are having a strong impact. At the policy level, I was really excited when I saw there was the woman from Chicago who was really interested in food insecurity and social determinants. I thought she was going to be the head of the FDA, but food and agriculture, I was really excited about that. She was from an urban area, but I thought had a good sense about sort of the downstream effects about food and agriculture, but they did pick someone who was more traditional, rural, agricultural kind of person. So I'm hoping that she will have a role and we can hook up with her in order to move some of these issues forward. So there's lots that we can do, and it sounds like that several of you have a good sense. And as we begin to roll out projects on this, hopefully in the next 6 weeks or so, we can post them for the group and see if there are students, residents, whomever, who are interested in a project related to this. So I know we can do some good things in our community, even in these bizarre kind of times. So I did put some references here. They're not, and I apologize that these are the things that we're going to do. I've already referred to those, and this is available online. But these are some of the references. I apologize; they're not in APA format. I was updating my sources in a minute, but I found some great. These 5 pieces are from this year and since the pandemic, and I looked through them all this morning, and they really do provide us with some good background information. So if you are interested in this, these are some good resources for you. And if there's anything that we can do on this project, we will keep it going. That is our intent. And we've got to sort of regroup and figure out how this fits in with the other things, and then to see about finding some funding, because one of the things even the legislators want to know is whether or not some of these interventions that we did in the community and the provision of vouchers is making a difference, both in the outcomes. Is it making a difference in people's health? And that's a long-term study. We need a 5 or 10 year study to find out if it makes a difference with populations. That would be a whole a pretty complex methodology, but it's doable. But it has to be done in the long term, but we can also get some measures at the individual level. Yeah, Kathy.
Yeah, I was just going to say, I think what I would do is even ask the primary care providers that attend this kind of a session, or that in fact are out there implementing some things, ask them what have they done in their practice in the past 6 months or in the past year, and actually have them account for, if you will, any interventions whatsoever, and then maybe to have them further look at data that they may be able to generate from their practices to further document.
And we can do something like that with our database as well. And Kings County, who's one of our partners in this, they have been doing screening. We had started talking with them about some interventions, and we need to move that further. So that's a ground that's all ready to go. So some of this stuff, it will not take a lot to put together, but I'm hoping we can find a way to get some small projects launched, but really to think about doing a major initiative. So closer to a random controlled trial, but maybe a natural experiment to find out if it really does make a difference.
Well, and also to get a question or two into our electronic health record. If not in the electronic health record, it isn't happening.
Yeah.
There's nowhere else to capture that unless there were something informal. And I mean, it's challenging enough to complete the electronic health record. So I guess that to me, is there a committee? Is there somewhere where this can be brought forward in the agenda and made to happen? Is there a question, if there's no room, that could be switched out in deference to this question?
Well, we have an opportunity in our project actually, because we're using, I'm pretty sure Cyan can speak to this more specifically, but we're using some of the CAPS measures, quality measures about experience with care. And there is opportunity to add your own questions there. We can look at the questions that that they're using at Kings County, because they have incorporated them into their EHR. And I know they're not in downstates, but I'm sure they're distracted at the moment with a million things, but certainly something we can think about. And I think we're going to have to think a lot about some of those EHR changes as we try to move for an age-friendly environment, to be able to, if you participate in any of those age-friendly sessions, you know that many of the organizations that are moving to an age-friendly environment have really spent a lot of times, and they have actually included these questions about what matters, mentation, mobility, and
yeah. Well, I would also, before that question about the veterans themselves, but or your family, because again, there's impact on numerous levels, not the least of which is mental health, let alone physical, and obviously, again, the food insecurity component.
Yes. So we have lots of great work to do, and we'll look forward to working with all of you as we move forward. And if any issues come up in the meantime, I'm sort of the point person for food insecurity, so and healthy eating. So just let me know, and we will do that. And on your evaluation, if you think we need to do some more specific things around nutrition, please be sure to put that in. So I thank you for your attention. Small but mighty group. We had some, and I've got some good ideas about things that we can and should be doing. So Cyan, do you want to, or Victoria, do you want to wrap up our event?
Can I make one quick comment, Dr. Girouard?
Please.
Yes, so I know the American College of Lifestyle Medicine, like for providers, if you're interested in learning more about that, the nutrition and food is medicine, that's a great resource. Lifestyle Medicine Interest Group, we're working on, it's in its infant stages, an initiative called the White Coat, White Apron Initiative. White Apron.
I'm writing it down.
White Coat, White Apron Initiative. It's literally in its infant stages, and so I say all of that just to say that, you know, there are some things going on at Downstate, and we're trying to get the community, specifically Central Brooklyn, access to nutritional food, because it is cheaper to eat more plant-based diets. As well as we have partnered up with Plant Powered Metro New York, and we're about to kick off a 21-day Jumpstart program to a couple of participants, and they will have to transition to plant-based whole food diets. And we're going to have twice weekly sessions to help them with that transition. And so we've also identified that not only will they do people not have misconceptions about whole food plant-based diets, but trying to come up with recipes that are comfortable for our target population. So traditional Caribbean recipes that have been changed to whole food plant-based diets, so they can still have that feeling of a home-cooked meal native to their country, just healthier. So just wanted to make
Anna, can you get me hooked up to that group?
Yes.
Thank you. And I think Carlene, I don't know how much time she's got, but we need Carlene to be linked in too. And then we can engage our resources together to make a difference. Thank you. All right. Thanks everybody. I got to run for my call, but Cyan, Victoria,
Yes, Dr. George, thank you so much. This is great that actually we had this 3 p.m. talk. And having this small group actually just made it more interactive. And this is great that Ayana, that you shared this information. Please send this information to all of us. This is very important for sure. And the 4 p.m. talk hasn't been canceled, so please follow up the link in the chat, and we'll see you in a minute. Thank you, everybody.
Happy New Year. Happier, healthier New Year.
Happy New Year.